When we think about modern medicine, there's this immense expectation of crystal clear precision. Like if you think about taking your car to a mechanic today, they don't just guess what's wrong.
Right, they just plug it in.
Exactly. They plug a diagnostic computer right into the dashboard. It spits out an exact error code, and the mechanic knows the precise bolt to tighten. And, we kind of expect our hospitals to operate the exact same way.
Yeah, I mean, we want medicine to be totally binary, like a clear input, a clear output, measurable, and highly visible.
We love a clear data point.
Yes.
But then you step into a labor and delivery room, and suddenly that precision is remarkably murky. Think about it for a second. You are trying to monitor a patient you cannot see, you cannot touch, and you cannot ask how they're feeling.
It's the ultimate locked room mystery, really. Because at its core, the physiological process of labor is fundamentally a stress test of a baby's oxygen supply.
Right.
Every contraction squeezes that environment, and figuring out how the baby is handling that stress from the outside, well, it requires an unbelievable amount of interpretation.
So, for our deep dive today, our mission is to decode the secret language of the fetal heartbeat. We are pulling from an incredibly comprehensive medical text, Intrapartum Fetal Heart Rate Monitoring and Assessment Methods, by Kitty Cashin.
It's a fantastic resource.
It really is. We're going to explore the fascinating technology used to track a baby's well-being, and we're going to uncover a surprising medical paradox about why hospitals monitor the way they do today.
Yeah, that part is wild.
So whether you are a medical student prepping for an exam or you're just insanely curious about how human beings survive entering the world, welcome. We are so glad you're here. Okay, let's unpack this. Before we look at the physical tools we use to listen to the baby, we really have to look at the history of this technology because it completely subverted my expectations.
Oh, absolutely. The history of fetal monitoring is kind of a classic story of good intentions colliding with some very hard statistical realities.
Which happens a lot in medicine, right?
All the time. So to give you the baseline, medical professionals have been listening to fetal heartbeats for over 300 years. Originally, they just, pressed an ear or wooden horn-shaped scope right to the abdomen.
Wow, just old school.
Very old school. But in the 1970s, electronic fetal monitoring, or EFM, made its grand debut.
And EFM came with this massive promise, didn't it?
It really did. The expectation was that by continuously monitoring the baby's heart rate on a screen, doctors could intervene at the very first sign of distress.
Right, to prevent long-term neurological damage. Specifically cerebral palsy. It was marketed as a total game changer. But the source text drops a major twist here. Research over the last 50 years has proven that continuous electronic fetal monitoring does not actually decrease neonatal neurologic morbidity.
It really doesn't.
It simply doesn't change the rates of cerebral palsy.
What's fascinating here is the underlying reason for that. It comes down to the fundamental difference between sensitivity and specificity in medical testing.
Okay, break that down for us.
So, as a diagnostic tool, EFM has extremely high sensitivity. That means if the monitor shows a reassuring, normal pattern, you can be highly confident that the baby is perfectly well oxygenated.
Okay, that sounds good.
It is, but it has incredibly low specificity.
Meaning it triggers a massive amount of false alarms. It's like buying an ultra-expensive, hypersensitive security system for your house.
Yeah, exactly.
It goes off every single time a leaf blows across the driveway or like a stray cat walks by the porch. You get a ton of false alarms, and the neighborhood statistics show it doesn't actually stop burglaries any better than the regular deadbolt you had before.
That is a perfect analogy.
But you keep the system anyway because everyone else on the block has one, and your insurance company expects you to have it.
And that's exactly what happened. We have this profound friction between clinical evidence and institutional habits.
It's wild.
Despite the hard data showing that continuous monitoring doesn't improve those long-term neurological outcomes compared to, say, just having a nurse listen periodically, EFM is used in over 80% of all laboring women in the United States today.
So if the data says this hypersensitive security system doesn't stop the burglaries, why is it literally everywhere?
Well, the text cites two main drivers, and notably, neither of them has to do with superior clinical outcomes for the baby.
Right.
First is the reality of hospital staffing. Continuous electronic monitoring means one single nurse can sit at a central desk and watch the digital readouts for 4 or 5 patients simultaneously.
Of course. It's an efficiency thing.
Exactly. The alternative requires dedicated one-to-one nursing at the bedside, which, many modern hospital systems simply cannot staff or fund.
And the second reason.
The rise of defensive medicine. We live in a highly litigious society. If an outcome is poor, doctors and hospitals want a physical, printed paper trail.
Like a continuous strip of data.
Right, proving they were watching the entire time. It illustrates how incredibly difficult it is to unlearn a generational medical practice once it becomes entrenched as the cultural and legal standard.
So if institutional inertia and, legal fears are keeping this flawed system in place, I want to know what this actually looks like for the patient. If you walk into a delivery room today, what exactly are you being hooked up to?
So we basically have a spectrum of options, moving from high touch to high tech. On the high touch end is intermittent auscultation, or IA.
Okay.
A nurse uses a handheld Doppler ultrasound, which is kind of like a specialized microphone, to listen to the baby's heart at specific intervals, say every 15 to 30 minutes.
And the text highly recommends this for low-risk births, right?
Right.
It's wildly less invasive. As the patient, you aren't strapped to a hospital bed. You can walk the halls, you can bounce on a birthing ball, you can even use hydrotherapy like a shower or a tub.
Yeah, the freedom of movement is huge, but again, it requires that one-to-one nurse staffing.
Right, which we just established is hard to come by. So what's next?
Moving down the spectrum, we hit continuous external EFM. This is the image most people picture when they think of childbirth in a hospital. Two elastic belts strapped tightly around the abdomen.
I've seen those in every movie ever.
Exactly. One belt holds an ultrasound transducer over the baby's back to pick up the mechanical motion of the fetal heart. The other belt sits at the top of the uterus holding a tucko transducer.
A tucko transducer.
Yeah, that device is essentially a pressure-sensitive button that measures the frequency and duration of the mother's contractions.
But the text notes these external monitors have major limitations. Because they sit on the outside of the body, they can easily be thrown off by simple movement.
Oh, absolutely.
Or, if the mother's obese, the signal just might not penetrate the tissue well enough to get a continuous read, which leaves the medical team just staring at a blank screen.
And that loss of data leads us to the most invasive end of the spectrum, which is internal EFM. If external monitors fail and the medical team loses the signal, they have to go inside.
Which sounds terrifying.
It is intense. Assuming the amniotic sac has ruptured and the cervix is dilated enough, medical staff can place sensors directly inside the uterus. To measure the contractions, they use an intraabdominal pressure catheter, or IUPC.
Okay, what is that exactly?
It's a fluid-filled tube that slides past the baby into the uterus to measure the exact strength of the contractions in something called Montevideo units.
I saw that term and had to pause. It sounds like a currency or something.
I know, it's a very specific term.
But from what I gather, a Montevideo unit is a calculation of pressure. The monitor takes the baseline resting pressure of the uterus and then calculates the peak pressure of every contraction over a 10-minute window and adds them all up.
Yep, that's it.
It basically tells the doctor exactly how hard the uterine muscle is working, leaving zero room for guesswork.
That is spot on. It measures the absolute raw power of the labor. But the IUPC only tracks the mother's contractions. To get the baby's heart rate internally, they use a spiral electrode.
Okay, I was trying to picture this. How do you get a better heartbeat signal internally? Are they putting a tiny waterproof stethoscope in there?
Not quite. It's actually electrical, not acoustic. A spiral electrode is a tiny corkscrew-shaped wire that is inserted through the cervix and rotated lightly into the presenting part of the fetus, which is usually the skin of the scalp.
Wait, really?
Yeah, it picks up the baby's ECG, the actual electrical impulses of the heart, directly.
Wait, a spiral electrode actually penetrates the baby's scalp while they're still inside. That sounds incredibly intense. Does the benefit of getting a clearer signal really outweigh the invasiveness of physically puncturing the baby's skin before they are even born?
If we connect this to the bigger picture, we have to remember the stakes of that locked room mystery.
Right, the oxygen supply.
Exactly. The entire purpose of monitoring is to ensure the baby's brain is getting enough oxygen to survive the trauma of labor. When external monitors drop the signal due to constant movement or maternal sighs, the medical team is essentially flying blind.
Which you do not want.
No. In those specific scenarios, getting an uninterrupted, highly accurate read on the baby's cardiovascular system isn't just a clinical preference, it's absolutely critical for safety. The technology being used must be tailored to the specific anatomical realities of the patient in the bed.
I guess you can't fix a problem if you can't see the data. Though it is relieving that the text mentions a new middle ground.
The wireless patches.
Yeah, there's a wireless patch system now, like the Novi system, that uses Bluetooth. You place adhesive patches on the mother's abdomen, and it picks up the ECG signals from both the mother and the baby, plus the electrical activity of the uterine muscle.
It's brilliant.
No tight belts, it's waterproof, and the patient can walk around. It feels like we are finally upgrading from 1970s hardware.
It is a massive leap forward for patient mobility and comfort. But regardless of whether the raw data comes from a Bluetooth patch, a tight belt, or an internal spiral electrode, that data eventually travels to a computer and ends up on a screen as a series of squiggly lines.
So let's assume the sensors are perfectly in place and the data is flowing. What is the nurse actually looking at on the screen? Let's decode this secret language.
Okay, let's hit it.
The baseline is the very first thing they look for, right? That's the average heart rate over a 10-minute window. And a normal fetal heart beats incredibly fast compared to an adult's. We're looking for a baseline of 110 to 160 beats per minute.
Right. Anything over 160 is considered tachycardia. Anything under 110 is bradycardia.
Okay, that makes sense.
The baseline provides the foundation, but the true indicator of fetal well-being is a concept called variability. Variability refers to the irregular moment-to-moment fluctuations in that baseline heart rate.
Here's where it gets really interesting. You'd intuitively think a perfectly steady heartbeat, like a ticking metronome, means everything is great. Just a flat, consistent, stable line.
That's what most people assume.
But it's actually like a person driving a car down the highway. If you look over and the driver's steering wheel is perfectly dead still, something is terribly wrong.
Yeah, they might be asleep at the wheel.
Exactly. You want to see those tiny, constant micro-adjustments to prove the driver is awake, alert, and actively reacting to the bumps in the road.
I love that driving analogy. Physiologically, those constant micro-adjustments are the visual representation of a tug-of-war happening within the baby's autonomic nervous system.
The tug of war.
Yeah. The sympathetic nervous system, the fight-or-flight response, is constantly trying to push the heart rate up. Simultaneously, the parasympathetic nervous system, the rest and digest response, largely controlled by the vagus nerve, is actively pulling the heart rate down.
So they are fighting each other.
Exactly. When you see moderate variability, those constant, jagged little ups and downs on the monitor, it proves that both systems are firing correctly. And the only way the nervous system functions that perfectly is if the baby's brain is heavily saturated with oxygen.
Wow. But if you see absent or minimal variability, just a smooth, flat line, that's a warning sign. It could mean the baby's oxygen supply is compromised.
Generally, yes.
Although the text does offer a caveat. Babies actually sleep inside the womb. A flat line for 20 minutes might just be a natural sleep cycle.
Which can definitely give new parents a scare.
Oh, for sure. Aside from variability, the nurses are looking for accelerations. These are sudden upward spikes in the heart rate, usually happening when the baby kicks or moves. Accelerations are the gold standard. They are the ultimate proof the baby is currently happy, moving, and well oxygenated.
So the monitor captures all these reassuring signs, the micro-adjustments, and the upward spikes. There's also a very rare visual called a sinusoidal pattern, which looks like a perfectly smooth, undulating ocean wave.
That sounds kind of pretty, actually.
It looks pretty, but it's a massive red flag.
Yeah.
It indicates severe fetal anemia, meaning the baby's blood is desperately low on red blood cells. But setting that rare case aside, the primary focus of the medical team is watching for the drops.
The decelerations.
Yeah.
If you are the one lying in that hospital bed staring at those squiggly lines, it's terrifying to hear the audible beeping of the heart rate suddenly dip low.
It's incredibly stressful.
But as a nurse, you have to look at the specific shape of that drop and, crucially, how it times out with the mother's contractions. The text breaks these down into three main types.
Right. First, we have early decelerations. Visually, these are gradual, symmetrical drops that perfectly mirror the mother's contraction. As the contraction builds in strength, the heart rate slowly drops. As the contraction fades, the heart rate slowly recovers.
And the mechanism behind this is surprisingly straightforward. The baby's head is getting squeezed.
Yeah.
As the baby descends, the contraction compresses the head, which alters the intracranial pressure. That pressure triggers the vagus nerve, which reflexively slows the heart down. It's totally benign. It just means labor is progressing. No medical action is needed.
Contrast that with late decelerations. These are also visually gradual drops, but the timing is dangerously shifted. The drop begins after the contraction has reached its peak, and the heart rate doesn't recover until well after the contraction is entirely over.
Why is a late drop so much worse than an early drop? I mean, they're both just drops, right?
A late deceleration points to uteroplacental insufficiency. It means that during the peak of the contraction, the blood vessels in the placenta are being squeezed so tightly that the oxygen transfer completely stops.
Oh, wow.
Yeah, but the baby has a small reserve of oxygen in their blood. It takes a few seconds for that reserve to deplete and for the brain to register the lack of oxygen. When it finally does, the vagus nerve kicks in to slow the heart and conserve energy.
Ah, so that's why it's delayed.
Exactly. Because of that delayed reaction, the drop happens late. It is a highly concerning sign that the baby's environment is failing them.
Then there is the third type, variable decelerations. Unlike the smooth, gradual slopes of early and late drops, variables are visually abrupt. They drop sharply and look like the letters U, V, or W on the monitor.
And the cause here is completely mechanical. The umbilical cord itself is getting compressed. The baby might be grabbing it, lying on it, or it might be wrapped around a shoulder.
So what does this all mean for the nurse staring at the monitor? It sounds like trying to read tea leaves while running a marathon. If a drop happens during a contraction, how on earth did they distinguish a harmless head squeeze from a dangerous oxygen drop in real time, especially when they might be monitoring 4 different rooms from a central desk?
This raises an important question about the immense pressure we place on our nursing staff. They are the absolute first line of defense. They are legally bound to document these specific mathematical shapes, properly identify the timing of a drop down to the exact second, and immediately notify doctors if a pattern shifts.
Right, because there's a tier system for this.
Yes, the national 3-tier classification system. Category 1 is completely normal and reassuring. Category 2 is indeterminate, kind of a gray area where you need to watch closely. And Category 3 is definitively abnormal. It means the oxygen supply is critically interrupted and immediate medical intervention is required.
It requires intense, continuous vigilance and highly trained visual pattern recognition from the nurses.
Absolutely.
So let's say a nurse spots that dangerous Category 3 pattern, a series of late decelerations showing the oxygen has stopped flowing. They have to spring into action. But they can't exactly reach their hands inside the uterus to help the baby. How do you treat a patient you cannot touch?
The clinical protocol for this is called intrauterine resuscitation.
Which sounds like a deep space rescue mission. It's an incredible term.
It really is. The overarching goal of the mission is to immediately improve blood flow to the placenta. The first interventions are structural. The nurse will rapidly change the birthing person's position, usually rolling them aggressively onto their left or right side.
What does rolling over actually do?
It unpinches the plumbing. The heavy weight of a full-term uterus can compress the inferior vena cava, which is the massive vein carrying blood from the lower body back to the mother's heart. By rolling the patient off their back, that vein opens up.
Oh, that makes total sense.
Right. A massive volume of blood rushes back to the heart, which means a stronger volume of oxygen-rich blood gets pumped straight to the placenta. They also open up the IV fluids to literally boost the mother's overall blood volume.
And if those structural changes don't fix the monitor's readings, they move to specific medical interventions.
Yeah.
I imagine if the contractions are cutting off the oxygen, the goal is to stop the squeezing.
Exactly.
So if the mother is receiving oxytocin, a drug used to force contractions, the nurse immediately shuts the IV off, give the baby a break. They can even administer medications called tugolytics, like terbutaline, which actively force the uterine muscles to relax and stop contracting entirely.
There's also a fascinating mechanical intervention specifically for umbilical cord compression called an amnioinfusion.
I read about this. It's wild.
It is. If the monitor shows those sharp V-shaped variable decelerations because the baby is repeatedly squishing their own cord, it often means there isn't enough amniotic fluid acting as a cushion. So the medical team can slide a catheter past the baby and pump room temperature sterile saline directly into the uterus.
Just literally refilling the pool to recreate that fluid cushion and float the cord free. I mean, that is just brilliant biological plumbing.
It really is an elegant solution.
But as I was reading this section, there was one detail that absolutely blew my mind. The big update on oxygen masks.
Oh, yeah. This is a huge shift.
Historically, the absolute standard of care when a baby's heart rate dropped was for the nurse to rush in and slap an oxygen mask on the mother's face. It makes total intuitive sense. Give the mother extra oxygen, she passes extra oxygen to the baby. But the text cites 2 massive recent studies showing that routine oxygen supplementation for the mother does not actually help the baby at all.
It is entirely counterintuitive, but the mechanism makes sense when you look closely. If the placenta is compressed and blood flow has stopped, pushing 100% oxygen into the mother's lungs just doesn't matter. The delivery highway is closed.
Right.
The extra oxygen simply cannot cross over to the baby.
It's mind-blowing that something as intuitive as give the mom more oxygen to give the baby more oxygen turned out to be useless. It really shows why medicine has to constantly test its own assumptions.
Rigorous testing is essential because human intuition often falls short of complex physiology. And, the ultimate scorecard for how well all of these resuscitation efforts worked doesn't actually arrive until right after the baby is born.
Oh, with the cord blood.
Yes. The team will pull a blood sample directly from the umbilical cord to test the exact pH and gas levels. That cord blood acid-based determination tells them definitively if the baby suffered metabolic acidemia during the process.
Acidemia. Meaning, did the lack of oxygen force the baby's cells to switch to emergency anaerobic metabolism, producing dangerous levels of lactic acid just to survive?
Precisely. The blood test provides the final binary answer that the monitors were trying to guess all along.
It is an incredible system. To recap for you listening, electronic fetal monitoring is a flawed but deeply embedded, legally driven tool that relies on reading the tug-of-war of a baby's autonomic nervous system to track oxygen. As patients, we want to see those jagged micro-adjustments of variability, and we want to avoid late decelerations. And the nurses are the highly trained pattern recognizers, executing intrauterine resuscitation when those lines on the screen go wrong.
They are the vital bridge between a machine's data and a human being's survival.
They really are. Now, to wrap up our deep dive, I want to leave you with a final thought to ponder. The source text mentions that if a nurse has trouble finding the baby's heartbeat with the monitor, it causes immense, immediate anxiety for the parents.
Which is completely understandable.
Of course. The text advises the nurse to reassure them by casually saying they're just finding the spot where the sounds are loudest. But let's take that psychological reality a step further for you to think about. In modern childbirth, does the glowing monitor in the corner of the room actually steal the spotlight from the birthing parent? We've created a medical culture where everyone in the room, the doctors, the nurses, the partners, and even the laboring parent themselves, ends up staring anxiously at a screen, trying to interpret digital squiggly lines.
We really do get fixated on the data stream.
Exactly.
Yeah.
We wait for the machine to tell us if we are safe, rather than focusing on the deeply natural physical experience of the human body right in front of us. What is the psychological toll of turning the visceral experience of birth into a data monitoring exercise? By seeking perfect precision, do we lose sight of the patient in the bed?
It is a profound tension. We trade physical presence for data, hoping the screen gives us control over the unpredictable.
At the start of this deep dive, we talked about that expectation of crystal clear precision, the comfort of the mechanic's diagnostic machine. But human labor isn't a car engine. And maybe treating it like one comes with a hidden cost we're just starting to fully understand. Thank you so much for joining us on this deep dive into the hidden language of the fetal heartbeat. Keep questioning the world around you, keep looking past the squiggly lines, and we will catch you next time.